next speaker is Athena Demertzi from the University of Liège. Athena is going to bring her unique perspectives on consciousness through her work on disturbances of consciousness as diverse as coma, anesthetics, neuromodulation, and other windows into the soul. So over to you, Athena. Thank you very much.
Yes, good morning, good afternoon, good evening. Thank you so much for the kind invitation. I'm very, very excited to be here. I'm very excited for two reasons. One is I feel that I'm playing in the Champions League of very respected researchers and mentors whose work I've been looking up to the last years during my work. And especially today, your commitment to be here from wherever in the world, whenever time zone, for me, it's truly inspiring as a young faculty. So thank you for that. I hope it will worth it. The second reason I'm very excited about is that this event combines two of my favorite notions, which is brain connectivity and consciousness, with unconsciousness being part of it. So why these two notions are dear to me? Why brain connectivity? Why unconsciousness? I could use the terminology of consciousness research and saying that why I'm interested in unconsciousness for me is the hard problem. Because if I'm trying to justify why I'm driven by something that I don't see, by something that, it's undetermined, most probably, I will end up talking about existential fears, daddy issues, and it's messy. So as the hard problem of consciousness, let's leave it aside. Let's say that it gives an intrinsic pleasure in finding things out and deal with the easy problem like why connectivity. So why brain connectivity for me is easy because during the past years, especially during the work we've done with in the clinical setting, brain connectivity, especially during resting state, has been an amazingly assisting tool in order to quantify the brain function and structure of patients who are unable to communicate. So imagine that having this challenge that we cannot derive any reportability of a patient, we have the simplest setup. We just put them in the fMRI scanner, we just press the button for 10 minutes, and then afterwards trying to make sense of what the brains tell us about their level of consciousness, maybe about cognition. So we started along the way focusing on the famous default mode network. And not only that, we were, along the years, we were realizing that the complexity of the default work of the default mind encompasses the work between several networks, like these task positive, task negative network. So that was an important work for us because with this anti-correlated activity, we were able to see how this antagonistic behavior was mediated in terms of the level of consciousness, like anesthesia, in terms of the environment, like we were involved in this European Space Agency parabolic flights, but also in behavior. So there is a counterpart of resting state and behavior and cognition, and we're able to quantify that. And using hypnosis as a modified state of awareness, we're able to see that these two networks change in comparison to what people say. So if you are more self-absorbed, your default mode network would be more active. If you are more attentive to your surroundings, the antagonistic task positive network would be higher. However, it's not only just two networks. We also adopted a systems level approach. In that case, it was independent component analysis. We looked at different brain networks that they were of long range or short range connectivity. And we found that these are severely disrupted in different patient categories. For those who are not, who don't know what kind of patients I'm talking about, these are patients suffering from disorders of consciousness. So you typically find yourself in disorder of consciousness after a severe brain injury, normally after recovering from coma. And if you are not able to communicate with your surroundings in a meaningful way, even when, yeah, in a reflexive way, you are said to be in an unresponsive wakefulness syndrome, the so-called vegetative state. Now, if you are to show a bit more complex behaviors like follow your image in a mirror, or follow simple commands like raise your index finger, but still unable to communicate, you're said to be in a minimally conscious state. So this is what kind of clinical populations we're dealing with. In that, with brain connectivity, we found that especially long-range networks like the, as I said, frontoparietal, left-right, DMN, but also some sensory networks like the auditory were severely disrupted. And lately, we were able to use brain connectivity in order to classify patients, single patients, in different categories. So this helped a lot the clinical reality, but it also gave us extra insights about how normal, typical consciousness is sustained. And lately, that was a very out of the scope of consciousness work. We work with hemispherotomies, and in that cases, people, especially children, they had to have their brains dichotomized to isolate the epileptic seizure. So in the right hemispherotomies, in that case, we were able to use brain fMRI, brain connectivity, and even try to classify the right and the left hemisphere of a patient that looked more similarly to the minimally conscious or to the unresponsive wakefulness syndrome class. So in a nutshell, brain connectivity has been an amazing tool to study different states of consciousness, but I have to measure to say here that this is about average connectivity, but we also know that maybe the answer about what kind of consciousness we're talking about lies in the dynamics, because we are living in a dynamic world. This is the work that I'm very, very grateful for to many people involved, especially a big consortium in the James McDonald Foundation, where we had the opportunity to bring together a lot of data from Belgium to Canada to the US. So we pulled together our data, and we were trying to see in the time varying domain how the brain function of patients, as we see here, unresponsive, minimally conscious, and healthy people configure across time. So we found that if we have like approximately 10-minute acquisition, so we have different type of brain patterns that they emerge from across time. So that was phase-based coherence. What we found was that there was a very complex pattern like this one, pattern one. We see here on top the regions of several of representative networks. So that was a granularity of 45 regions of interest, if I'm not mistaken. We see how the regions talk together in a positive, negative way, long range, short range. And if we see how often this state appears in different consciousness states, we see that it's more prevalent in the healthy people, more than patient groups. In stark contrast, well, there is a pattern where interregional connectivity is very, very low. And this pattern appears mostly in unconscious patients, as we see here. Then we have two other patterns that they did not appear preferentially in one or another group, as we see here in the rates and the probability rates. There is this pattern of all-to-all positive connectivity, and this one that is driven mostly by anti-correlations of the visual network. And I will come back to that of how we can put out together. But let me say a bit more about how we can further characterize these patterns and what they can mean So if we see here how the functional connectivity resembles to the anatomy, the underlying anatomy. So this is the similarity between the functional matrix and the structural matrix. We see that here pattern 4 has higher resemblance, similarity to the underlying matrix. And about complexity, when we had our paper and the review, the reviewers asked, like, what about complexity? You talk about complexity, what it means. So this is how we did it. We used graph theory, where we checked different properties like efficiency based on the path length of the graphs, entropy. This is spatial entropy. It seems like it reflects like the distribution of the edges of the graph. So the higher the entropy, the more normal the distribution of the edge weights. And then in terms of integration and segregation, these reflect on the component, the largest component of the graphs. So we can see that especially these let's say a simplest pattern is characterized by lower integration and higher segregation. But the real dynamics we answered by means of Markov entropy, where we show that here in black arrows, like the higher you are in a consciousness level, so going from healthy people to minimally conscious and non-responsive state, you have more chances to leave this complex state for traveling and entertaining other patterns, and have also high chances in re-entering it than when you are other way around. Like the less conscious you are, the more chance you have to entertain a simple pattern and leave it only for other simple patterns. Now, from all that, what it means in terms of cognition, we kind of here characterize maybe the global level of consciousness, but can we say something about behavior? Well, in that paper, we said like if we see the ratings, the appearance ratings of let's say this simple pattern that also appears in healthy people, we kind of hypothesized that might be the case that this can be the counterpart of the so-called mind blanking. So mind blanking, what I mean is like phenomenologically, how I mean it is like as contentless thinking. So we thought that maybe the brain is unable to integrate in such a way that it can give rise to this particular phenomenology. However, when I was about to formulate it in a more, let's say, experimental way, I was very lucky to have my mentee who said, you know, Athena, look also at pattern 3, and let's consider also theories of consciousness that say that at the same time, like when a brain is so overly connected, interareally, I mean, there might be also good reasons that we don't entertain any kind of thoughts. So which one could reflect the reality of mind blanking? We had the chance to do that thanks to colleagues that they used an experience sampling task. So if we can see here a long time, people were resting for some time, then they had a beep, which prompted them to give a response about how they have been before the beep here, this kind of period. So they responded, the responses were about stimulus independent thoughts, sensory related, but also they had the chance to ask whether people experienced mind blanking, the phenomenology that they did not think of anything. So they traced the data to us, and we followed this approach to arrive to the answer to the question, which break pattern looks most closely to mind blanking. So we took the resting periods, we used phase-based coherence, now with a different granularity, used the Schaffer Atlas. For me, it was very happy moment to see that even in a different data set, that we don't have pure resting periods, but it's part of the resting state, is part of the paradigm. And with different atlases, we arrive to similar patterns. So again, we have the complex pattern, the one that is driven by the visual system, the all-to-all connectivity, and the symbol connectivity. And when we checked how much they appeared during these patterns across the acquisition time, we found that in that case, pattern 4 was appearing more often, and we can come back to that. Now, if we take now the scans that they come after the people give the response, and we calculate the connectivity matrices and estimate the cosine distance of these matrices to what we estimated during resting period, then we can come closer to answering the question. So here we can see how the cosine distance between the response type and the resting state patterns look like. So here is the mind blanking minus the sensory periods, mind blanking minus the sensory, the stimulus dependent and stimulus independent thoughts. And we saw that actually what was happening, it was like, it was, the mind blanking was closer to the overall positive functional connectivity pattern. And in that case, my mentee was right. And I lost our bet. I don't want to take most of your time. I just want to summarize that brain connectivity for us is precious to consciousness research, not only to clinics, but we have good insights, very good insights about what happens in typical consciousness. Complex brain configurations most probably are linked to reportability of experience. On the other side, simple brain configurations are mostly linked to unconscious and unable to report states. And to conclude, it's like, for us, like a dynamic brain pattern must be better mapping the complexity of the dynamic world in a better, I'm sorry for that, in a better way. Thank you, and I'm very, very happy to discuss further. It's good.
Okay, well, thank you very much for that tour de force of functional connectivity in pathological and also normal sort of fluctuations in awareness and concentration. And as beautifully but demonstrated in an impromptu manner by your phone coming in there and creating a mismatch. Just to get the ball rolling, very interesting with the brain damage work that you showed. And I wonder, did you follow any of the clinical participants' recovery, and were there any sort of fingerprints in the data that you were looking at, like that preempted how they fared in time?
So recovery, indeed, like prognosis is one of the most, the hottest questions in clinical research. It's like how we can find, how we can use the paradigm to say whether people have chances to recover consciousness. I'm thinking here mostly of challenges rather than having answers. And this has to do with the fact that to follow patients in different states of during the recovery is by itself quite intriguing in terms of logistics in the first place, and in terms of recovery rates. What I mean by that is that most of patients, for example, that they find themselves in a responsive state, they have very few chances to recover, that we know from clinics for many, many years. Now, in the few cases that we can have a follow-up, the other challenge is that under which conditions they've been scanned. So in the early stages of the disorder, patients classically receive anesthetics to stay steady in the scanner. So the radiologist can have a very, very clear pictures of the structural anatomies. And later, if they recover, they can be scanned in an awake state. So methodologically wise, we're having this comparison issue, like the the anesthetized brain and the awake brain in brain damaged patients. So you see how the level of challenge is building up. In terms of, so I'm thinking also that we have done some work, especially with Dr. Whitfield Gabrielli, using the anticorrelations in some of the patients that they were followed. And these are results that we have not published yet, but we are preparing. So unofficially say that it's kind of the negative predictive value. In that case, if you don't have these system agonistic antagonism, you have less chances to recover to a higher consciousness state. But so far, what the comparison that we can do is like not longitudinally, but intersectionally. So you have this kind of group, and then of UVS, then you have the MCS and so forth. But definitely, like this is the next big question. And I think it can be answered not only by having one metric, but different metrics. So by combining different measurements, that either this is complexity, antagonism, or even more like simpler, let's say bold signal properties, like the spectral parts of the signal.
Mm-hmm. Okay, yeah, so there's lots of diversity in the data that you're acquiring. There is a technical question that's come through, and whenever you get N patterns, this is by Xenia Kovaleva, you could always also imagine you might change a parameter and get, in your case, 5 or 3. How did you come up with these 4 magic networks, and how sensitive was that number to different choices of your analysis pipeline?
Yeah. So when we were exploring and characterizing the states, indeed, the centroids were ranging between 3 up to 7. And afterwards, like the more centroids were asking, we were finding that these 4 patterns that were recurrently appearing. So in all of these the k-means clustering. And so we said, okay, if they are appearing recurrently, maybe it makes more sense to concentrate on these 4. And that was done first in our data set that included, I think it was patients scanning Liège. And then we checked how these would appear in the same way in the other data sets from the other centers. And the resemblance was striking. So that's how we concentrate on these 4, even more to make them more meaningful for the discussion terms.
Okay. And you found similar, if I caught you correctly, when you did a different anatomical parcellation as well, and in a different data set completely.
So the anatomy and anatomical parcellation, it was not performed at the single patient level. We had in the Sense Advances paper, we used the diffusion spectrum imaging because we did not have the DTI from every patient. So we decided to use a mean anatomical matrix that we downsample to have it in the same granularity as our functional data. And we compared this functional anatomy to our functional structural to function. Now the DTI is very, very messy with clinical data. So we would have lost a lot of power if we were to use that. And we know that DTI is quite challenging to have it in patients. Yeah. So but the way that it helped, the way that the structural function relation helped, at least to me, is to understand the purpose, especially of the simple connectivity pattern. It seems to be more prevalent even in healthy people, conscious people, I mean. And the fact that it correlates so closely to this part functional to the anatomy, it's like it's something that is always there. We have it there by default. And um, now what we're checking is like the diversion from this structural connectivity, how much is correlated to different conscious states. So kind of mental flexibility as a proxy to that, if you want.
Okay. So we have another question by Andre. Do you want to unmute there, please? Andre Lupi.
Hi. Yeah, thank you for another great talk. I was just wondering, since you brought up the anti-correlations, and that is a bit of a topic that many people have different thoughts about, and so I was wondering, what are your particular thoughts on anti-correlations? Not perhaps just as a way of diagnosing or detecting the presence of consciousness or not, which I think your work has contributed to establish, but also more in terms of the actual biology that is going on. What is it that they really reflect in terms of how different brain regions interact? Yeah, thanks.
Yeah, thanks. Nice to see you here. Yeah, that's a great question. Actually, we're preparing kind of a perspective of how the anticorrelations, how they rise in terms of bold signal physiology, and how given how they can be used in, especially in different theoretical models of consciousness. So from other understanding is like the anticorrelations are most probably reflecting neural inhibition. So they are there to as a they're like this is the reflection of neural inhibition. And in terms of theoretical models, like we have the IIT and the global neural workspace talking about how this inhibition by itself is so important to give rise to meaningful and I say informative thinking, let's say, and consciousness, like the content, as we say. So it's not only about being able to integrate. We don't need everything to be connected to everything, but we want things to be a bit more channeled, and this can happen through neural inhibition. This is the direction that we're taking into. It's like the brain needs to understand that it does not only need to receive, but also needs to know where to go. So it has to say no to some things and give pass to others.
On that note, interesting that there's no connections or no transitions between pattern 2 and pattern 4. So figure 2 of your Science Advances paper shows and you showed it in your talk, patterns of connections, but it's not possible to go directly from pattern 2 to pattern 4. If I can bring that up.
Yeah, I'm doing it.
Yeah, exactly.
So pattern 2 to pattern 4, yes. Pattern 2 to me, it's still a mystery. I mean, I keep it in mind of what it can mean, why it appears, why it's still so evident in the codification of patterns. There is some hypothesis, but this is something we'll have to check. It has to do with mental imagery and the ability to imagine. It was a very recent talk that a discussion we had about this, people with about like mental imagery especially, and how the visual cortex and the correlations of the occipital cortex to the rest of the brain there is critical for that. and it's very interesting that we discuss that now, because as we are here, it's like the hypothesis ahead is like to check immediately the brains of patients with aphantasia syndromes, like that these are neuropsychological patients that they cannot imagine things. I'm trying to see whether if we have the resting data, this pattern would be affected or not. These are very rare cases, so if you guys, everybody here is dealing with that, I would be very, very happy to have this data and have a look at that. This is my first hypothesis. But now, why pattern 2 and pattern 3 do not interact? I have no idea.
Okay.
No hypothesis.
Okay. Well, it certainly speaks to the sort of very specific types of patterns and dynamic transitions in the data. Randy, you have your hand up. Do you have a question?
I have a comment and a question. I promise the second one's a question. The comment actually goes back to some of the discussion. I think Andrea raised a point about anti-correlations, and Athena, I think you made the suggestion you could interpret them potentially as inhibition. I just want to make a connection to some work that we had done a long time ago looking at, it's actually proposed the idea that you can look at inhibition from a number of different scales, so that we need to be cautious, of course, that when we're looking at things like fMRI,
Totally.
or even G for that matter, that the inhibition that we think we're actually getting is an ensemble level, I'll call it emergent feature, or ensemble level activity, could be a aggregate feature of it. So I propose an idea of ensemble level inhibition, which could be sort of a cascade effect from the collection of inhibition and excitation at the cellular level. And that's okay, because it still makes the same point that inhibition and excitation balance across different scales is important, but how they manifest could be different if you look at the cellular level versus the population level. There's some really good examples in modeling work, and as well as some work from, I mentioned Alanda Steck's paper in PNAS that I posted yesterday, where they find that you've got very local excitation underlying sort of a broader inhibition. So you could envision that actually you might see very high excitability in the local circuit, but if you look at a higher scale, it may actually look like inhibition. So it's sort of that interesting balance between not only scales across the brain, but also across scales from the cells to the ensemble level. It makes it more complicated, of course, but I think that's also speaking to the fact we need to be very cautious about using inhibition, assuming it's actually something like a GABAergic effect, for instance, when we're not really measuring at that level for fMRI.
Absolutely, absolutely. On that case, on that level, it's Nikos Logothetis has done extensive work, like trying to see what's the meaning, the neural meaning of the Bolt signal, and that's how I build up on his observations. I mean, it's still speculation because the Bolt signal is still representative of it's an extra representation. It's not even like, it's measuring not neuronal activity, but hemodynamic, the hemodynamics of it. So it's an extra level of description. Yes, absolutely, I agree that it has to be with caution.
Well, this also kind of speaks at something that I think it was actually Giulio who raised the idea that there's a certain scale at which information integration is actually optimal. And I don't know if we have an answer for that yet, like which level is actually the best, especially for the things that you're looking at. For example, emergence of consciousness, it could be the case that what you're looking at in terms of scale is actually perfect. But for other phenomena, you may have to go to either a higher or a lower scale to actually capture the critical information for the function to manifest, like vision, for instance, or something like that. Anyway, sorry, that's a bit of a segue. The question actually has to do more going back to sort of the clinical utility of what you're measuring. And you mentioned, I think, earlier in your talk that some of what you're looking at was actually group level statistics, and you start segregating the groups into the smaller components and this is actually in the slide here as well. So I'm wondering if you could envision, for example, using the patterns you see here as getting back to the idea of templates. You have a single patient coming in, unclear what the diagnosis is. You run a resting state fMRI scan, and then say, here are the configurations in terms of the, I guess this is leading eigenvector applications. Here, LIDA was used. Was this LIDA that you used for this particular application, or hidden Markov models?
For the transitions, or for the estimation of the patterns? Estimation
of the patterns.
That was k-means.
That doesn't really matter, actually. But anyways, the idea is that you could, again, use these patterns as filters and say, well, this patient is likely in this X state versus that Y state. So it's getting back to the idea of individual application and personalization.
Yeah, yeah, that would be the clinical translation of this work, totally. And yeah, in the past we've done the classification that we tried in the past, that we can see it here. It had certainly to do with predefined patterns. So we knew that after, for example, ranking the different systems and how they could differentiate between the two conditions at the single subject level, we wanted to extrapolate to generalize to unseen data. So yeah, here we can see unseen data and how using this pattern that has this cross-modal connectivity, and I said cross-modal because it occupies, concerns auditory and occipital regions.
Oh, nice.
That for me, it was very interesting to see because it was building up from previous work. So previously we found the auditory network to be among the networks that they were severely disrupted in unconsciousness. And then in a later work, it appears that it was this kind of connectivity that was characterized mostly minimally conscious patients and healthy people. So we also tested on healthy controls. So all healthy controls were having this cross-modal connectivity preserved. But when this was disrupted, so these three features, we used three features, were not talking to each other, we had more chance to have the unresponsive wakefulness syndrome. So when we thought that this auditory network, auditory in the terms it's historically used, the word, right? Yeah. But it had this implicit bias that maybe it's the scanner noise, for example, that can be triggering it. But while we see how the topologies look like, it seems that it has to do something a bit more like multisensory integration story here. And that it gave rise to later hypothesis about how the typical brain works. Now, yeah, if we come back to how this time varying approach can work in clinics, yes, it's another yet work to do, and I would really like to try that. I don't know when at the moment. Yeah, it's quite of yeah. I would love to do that for sure. I don't know when.
No, I hear you.
If anybody wants to help, I would be very, very happy.
Super. Thank you, Athena.
Yeah, I'm tempted to pursue the conversation connecting your work with Gustavo's, because it seems like a intriguing opportunity to see whether energy across scales changes as a function of consciousness. But maybe we'll come back to that, because questions have popped up in the Q&A window, and I'll first ask Dan Lurie to unmute himself. Dan.
Yes, thank you. This is really, I think, interesting stuff, especially considering the theme of this year's workshop. And I was curious, I remembered this paper on lesion network mapping to try and identify essentially a common site. And then I went to look it up and realized that you're on that paper. And I'm wondering if you could maybe comment on kind of an opposite idea to degeneracy in the brain, right? So how we may get the same phenomena from the same mental state from different patterns of brain activity. Could we potentially get the same kind of type of disorder of consciousness in terms of these different functional states, both from a brainstem lesion and also from like a traumatic brain injury that's just more kind of like diffuse damage to long-term axonal connections? and like what kind of the bridge is between, you know, these, if that is indeed possible, what the bridge is between these two different types of damage causing the same type of functional connectivity patterns.
Yeah, I totally align with our view that, so if I were to rephrase, is that we benefit from comparing within different categories, brain injury categories, than having all the time the healthy brain as the control model, right? The healthy model. So if we consider what the damaged brains bring, maybe we can even have more insights about how the brain and the mind configures. So the lesion brain mapping, indeed, like it was the contribution of Dr. Fox, Michael Fox, that he asked data specifically from comatose patients. So these are patients that are not even able to open their eyes and interact even reflectively with their environment. So we're in a coma, we don't respond to even a very painful stimulation. So what they did is, like, they were trying to find the anatomical pathology, the pathophysiology of coma, and then they specifically considered the brainstem, and using these regions anatomically defined as regions of interest, then we can see what kind of brain networks they arrive. So Dan, if I'm answering your question, is that, like, if I understood correctly, it's like how we can use get information from this about consciousness.
So essentially, the idea being that there may be, could there be, you know, so you're looking at functional connectivity networks, right? And so could there be different types of pathology underlying the same types of consciousness, right? So like one being a more focal brainstem damage versus a more diffuse kind of cortical, intercortical connectivity damage.
Yeah, totally. We can have the same clinical picture coming from different etiologies and brain regions, and that it's an extra complication level when it comes to predicting, to prediction, like single patient predictions. We should take the etiology into consideration. Yeah, it's kind of yeah, you're absolutely aligned there with you.
Our next question is in a similar way, but it might force you to be a little bit hypothetical. But if you look at where the brain, well, Eric, do you want to speak up and ask your own question rather than me paraphrase it?
Yes, thank you. Can you hear me?
Yes.
Yeah, thank you for the talk. Yeah, I was actually wondering, because I like quickly skimmed through your science paper where you showed these patterns, and you clustered the functional connectivity matrix in non-overlapping in a non-overlapping way. And so there has been also other approaches where we looked at kind of like overlapping clusters to find important nodes. And I think there's also a paper actually from Dr. Breakspear showing that the more central, like these nodes that are present in different clusters, could have a significance in how much or how deep of a vegetative state the patients are going to be. So in other words, if there's a lesion in a very central node, that the prognosis for the patient might be poorer than if it would be in some other non-central node. So I don't know if you have any insights on or any ideas of the role that might these nodes play.
Actually, no, I did not. I do not have any like evidence-based information about that, because we did not test it. But it's very interesting approach to see which kind of whether there is a kind of particular topology within this big connectome, like whether this can inform about prognosis, even diagnosis in patients. But I don't have more ideas about that. That's a very, very nice, insightful question.
Thank you.
If you have predictions about this and where and why, that would be very nice to hear.
Yeah, I think you might be referring to this very, I don't want to say old, but 2009, where we did virtual lesions across the connectome. This is with Jeff Alstott and Olaf. And there was a lot of heterogeneity in the relationship between the location of the lesion or the simulated lesion and the effect on functional connectivity, as predicted in this virtual laboratory. And the midline areas, particularly, yeah, I wonder if it even overlaps with some of the regions that you showed at the beginning of your talk that were the most influential on the brain dynamics that ensued. Let me just see if I can show this. So I've got a few minutes.
Was it on my slides? I can share it. Oh no, you're good.
Well, I think, can you see this?
Yes.
If I remember correctly, these were the areas that when virtually lesioned had the greatest effect on functional connectivity as simulated. And I could be wrong here because it was 12 years ago. But that does remind me of the slide that you opened with on these two interacting and sort of diametrically opposed regions. Can we go back to you now? Trying to multitask here. Yeah.
Oh, the system antagonistic systems, you mean?
Yeah.
Yeah. That would be this one. Yes.
Yeah, sort of an interesting, intriguing overlap there.
And your question is whether this.
Oh, when we did these virtual lesions, these were the areas that had the greatest impact when we excised them from the virtual brain.
Yeah. Yeah. So I want to say that this illustration, it's just like a very specific time series from the default mode and the frontoparietal network. So yeah, I mean, it just, yeah, like for illustration reasons, but the fact that these frontal and mesiofrontal regions are involved, I think this is where you're pointing at, right? That might be of interest for the lesion map. Yeah. Several thoughts about it. Several thoughts about the frontal versus the back part of consciousness, like Giulio Tononi was mentioning, but also in terms of executive function and all these different properties of consciousness. I align with the view that it's not just one thing. So we have these global states, but we also they are characterized by different properties. Either it's executive function, memory, attention, arousal, vigilance, and so forth. It's like a constellation of functions that they can support it. And in that case, the prefrontal cortex and mesiofrontal cortex are quite important. And maybe the most easily affected when it comes to pathologies.
Okay, well, one last question that's come up in the Q&A box, if I can find where it's gone. Oh, where has it gone? Okay, an anonymous question. First of all, do you think it's a better idea to take subject level fully connected matrices and perform clustering to get sparsely connected matrices for further analysis, or apply thresholding on the entire matrix before you do the clustering.
Subject fully connected from functional activity and perform clustering to be sparsely connected. I'm sorry because your accent is very exotic to me. I have to read. And so the first question, like, what is essentially the question here is like you think that we would arrive to different patterns if we do this, or what is why the idea is better? In what sense?
Yeah, I guess the question's speaking to how many iterations of the analysis pipeline did you have to explore before you found these four, distinct networks that differed across your patient groups? So was it immediately obvious that you should do the clustering and then
Yes.
Yeah, okay.
Yes. It was set from the beginning that we would go for this approach. It was set from the beginning we were going for phase-based coherence and not a sliding window. We had the methods predetermined and we did not change that. And fortunately, by that time, we did not pre-register to prove that point. But we learned from the past.
It's a fairly it's a fairly well established way of looking at the data. And the Hilbert transform, obviously just extracting out the phase and not being contaminated or not being biased by amplitude effects.
Yeah.
That's why you chose the Hilbert transform?
We did not take the amplitude into consideration, indeed.
Yeah. Did you have to filter the data before? I mean, everybody filters bold data to some degree, or either notch filters or smooths or regresses out confounds. The Hilbert transform can be a bit vulnerable to sort of discontinuities or noise in the data in terms of suddenly having phase wraps. Did you have any issues like that, or did the bold data give a fairly unambiguous phase?
I don't have a clear picture on that. I have to go back, but so the question is like whether we applied filtering before we transformed.
Yeah.
Yes.
EEG data doing the Hilbert transforms a really complicated thing because the data has one on F noise and it doesn't have an unambiguous phase. But the bold data generally is smoother, but still it can have respiratory artifacts that could be different across the groups, etc.
Yes, no, I have to go back to the methods that I don't remember. I'm so sorry that I cannot answer this at the moment. But maybe Seper, my mentees here, Seper, you've done it so very recently, the analysis. If you're here, you can hear me. Can you contribute to the discussion, maybe? Yes.
Hello, can you hear me?
Yes.
Okay, hello everyone. Yes, you're right. Before Hilbert transform, we performed a very narrow bandpass filtering because for Hilbert transform, you need a very narrow frequency band. If you don't filter your data, the results won't be correct. So even after pre-processing that we bandpass filter the data, I think from 0.001 till 0.08, it was for pre-processing. But for Hilbert transform, we also filtered the data even more narrower. And if I'm correct, I don't remember correctly, but if I remember, it was from 0.04 to 0.07. So it was a very narrow band filter.
Okay, well, thank you. That's a great example of a virtual conference when you can have people who did various parts of the analysis suddenly jump in, possibly from a different part of the world. So thank you. Just the last question, and a little bit goes back to the discussion we were having with Rosalind. When you have a fingerprint or a decomposition of the complex brain dynamics in two different groups. And then you've got a virtual toolbox like the virtual brain. You could try and explore perturbations or lesions or stimulations to try and normalize the pathological group. I don't know if you have any thoughts about that, Athena, but it does sound like an intriguing way to sort of personalize therapy for patients with traumatic brain injury.
It's new to me. So, can you hear me?
Yeah.
This is a new view to me, so I don't have any particular thoughts. But
Well,
yeah,
I'm just thinking you could take this these four brain networks, the fingerprints, and the transitions between them in the brain traumatic brain injury group. You know, you showed that the participants sort of got stuck in this fourth network, and in a sort of virtual framework, you could, you know, change the parameters. This is the sort of work that Petra and Gustavo do, and try and normalize the dynamics, and that might give you novel insights into the sort of neuromodulation therapies that might work.
Totally. Now I get it. Yes, absolutely. Absolutely. Yeah, absolutely. Like where to start from, because in terms of therapies and neuromodulation, sometimes the question comes from where do we start? Is it the dorsolateral prefrontal cortex that, for example, like TDCS is asking us by default to start from there? Or can we go deeper with TMS, or even with drugs, like which agents can promote better or inhibit others more? Yeah, totally. It can be very, very insightful for therapeutic reasons. And I have to say that I'm very, very jealous that you guys are mostly engineers, computer scientists, and physicians, from physics. I'm from psychology. I wanted to be a physicist. The educational system did not allow me to do both, but I have the great chance to interact with you guys, and I learned so much. I'm very, very close to that. I'm not myself a physicist, but I'm very dear by what you guys doing.
Well, it's a lovely multidisciplinary community. So yeah, thank you for your wonderful work.